The fundamental promise of pharmacology usually relies on this comforting illusion, I think.
Right, the perfect lock and key.
Exactly. You administer a drug, it finds its specific target receptor, the disease is neutralized, and, the healthy tissue is just completely spared.
Which is a lovely, clean narrative, but yeah, when you step onto an oncology ward, that narrative completely shatters.
It really does. You aren't just managing a disease anymore. You are managing a physiological battlefield.
It is the absolute definition of collateral damage.
Mm.
I mean, every time we introduce a compound toxic enough to kill a malignancy, we are pushing the human body to the absolute limits of its biological tolerance.
Yeah.
The line between the mechanism of action and the mechanism of toxicity is, well, it's incredibly thin. And sometimes it just doesn't exist at all.
Welcome to today's deep dive. Whether you are a medical student prepping for boards, a young professional stepping into clinical oncology, or just a dedicated self-learner trying to map out modern medicine, we are thrilled to have you with us.
Absolutely.
Today, our guide through this battlefield is the Handbook of Cancer Treatment-Related Toxicities. It's a really rigorous, incredibly detailed text that documents exactly what happens to the human body under fire from modern therapeutics.
And our goal today is to serve as your ultimate shortcut. We're going to extract the core physiological mechanisms behind cancer therapies and, the specific toxicities they cause.
Right, because we want to give you a comprehensive, scientifically rigorous framework.
Exactly. The objective isn't just to memorize a list of side effects, but to truly understand the why and the how, so you can actually recognize and manage these critical adverse events in practice.
So let's start with the foundational treatment paradigm, the blunt instrument.
Right. Cytotoxic chemotherapy.
Exactly. To understand modern oncology, we have to first examine this traditional systemic approach, which is basically designed to target all rapidly dividing cells. But let's look under the hood. How exactly do these compounds work, and why is the collateral damage so severe?
Well, cytotoxic agents attack the literal machinery of cellular division, but they do it in a few different ways. Take pyrimidine analogs like 5-fluorouracil.
Right, 5-FU.
Yeah, they act as molecular decoys. They look like the normal building blocks of RNA and DNA, so the cancer cell absorbs them, tries to use them to replicate, and the replication machinery just jams.
It's like throwing a wrench into the gears.
Exactly. Then you have alkylating agents, which physically cross-link the DNA strands so they can't unzip to be copied.
Oh, wow.
And then anthracyclines, like doxorubicin. These not only inhibit the enzymes that untangle DNA, but they also generate these massive amounts of free radicals that physically shred the cell's genetic material.
But the drug doesn't know the difference between a rapidly dividing lung tumor and, say, a rapidly dividing hair follicle.
Right, or the lining of your gut or your bone marrow.
Which brings us straight to bone marrow suppression. The textbook dives deep into chemotherapy-induced neutropenia. Now, for our clinical listeners, we know neutropenia is an ANC, an absolute neutrophil count of less than 1,500.
Right.
But the physiology of why it drops so precipitously is fascinating. It's all about the non-marginal pool, right?
Precisely. Neutrophils have an incredibly short lifespan. We're talking hours to maybe a few days. So to keep you safe from ambient bacteria, your bone marrow is constantly churning out a massive supply.
Like a non-stop factory.
Exactly. But the actual circulating soldiers actively patrolling your bloodstream, that's the non-marginal pool that only constitutes about 4 to 5% of your total neutrophil stores.
Wait, only 4 to 5%?
Yeah, it's tiny. The rest are maturing in the marrow or stuck to the blood vessel walls. So when chemotherapy shreds the rapidly dividing stem cells in the marrow, that production factory shuts down instantly.
Wow.
Because the active non-marginal pool has such a high turnover, it is wiped out in a matter of days, leaving the patient profoundly vulnerable to opportunistic infections.
And it completely decimates the red blood cell line, too. I mean, chemotherapy-induced anemia is so prevalent that there's a specific scale used to assess it called the FCTN scale.
Right, the functional assessment of cancer therapy anemia.
Yeah. And it's a crucial reminder that anemia isn't just a low hemoglobin number on a lab chart. It translates to debilitating cellular level fatigue because the body literally lacks the oxygen transport necessary for basic ATP production.
It affects every single organ system. And moving from the marrow to the mucosa, we see another devastating consequence of attacking rapidly dividing cells, oral mucositis.
Now, previously, I always pictured mucositis as essentially a chemical burn from the chemotherapy washing over the tissue.
A lot of people do.
But the textbook completely reframed this for me. It describes a biological cascade, this 5-phase model by Sonis. It's not a burn. It's a runaway self-destruct sequence.
That's a perfect way to describe it.
Yeah.
The chemotherapy doesn't just burn the surface, it penetrates the basal epithelial layer
Yeah.
and causes direct DNA damage.
That's the initiation phase, right?
Exactly. And that initial damage forces the cells to release reactive oxygen species, or ROS. These free radicals act as an alarm bell, activating a transcription factor called NF-kappa B.
And that's the signal amplification phase.
Yes. Once NF-kappa B is activated, it triggers a massive release of pro-inflammatory cytokines like TNF-alpha.
So this creates a positive feedback loop. The inflammation causes more tissue damage, which causes more cytokine release, rapidly amplifying the signal.
Exactly, leading to the ulceration phase.
Uh-huh.
The tissue literally turns on itself, creating severe, agonizing ulcerations where secondary bacterial infections can take hold.
It's just brutal.
It really is. And it only stops the healing phase when the drug is cleared and the surviving stem cells finally begin to proliferate and rebuild the tissue.
Okay, let's unpack this. If cytotoxic chemo is causing the systemic, unavoidable damage to the GI tract and the marrow, we need a way to shield the healthy tissue.
Right.
The text mentions a fascinating prophylactic technique for 5-fluorouracil. You have patients suck on ice chips oral cryotherapy during the infusion, and it dramatically reduces mucositis.
It's incredibly effective.
So I have a physiological question for you. If oral cryotherapy works by causing local vasoconstriction, physically clamping down the blood vessels to reduce drug delivery to the mouth, why can't we use regional cooling to protect other vital organs, like the liver or the bone marrow?
It's a brilliant theoretical thought, but practically impossible because of your body's autonomic temperature regulation.
Oh, right. Homeostasis.
Yeah. Your core organs must be kept at a rigorous 98.6 degrees Fahrenheit to maintain enzyme function. If you attempted internal cooling profound enough to cause local vasoconstriction in the liver or the long bones, the hypothalamus would trigger massive systemic shivering.
Just to fight the cooling.
Exactly.
Yeah.
Massive metabolic heat production to fight you, eventually leading to lethal systemic hypothermia. You simply cannot override core homeostasis. What's fascinating here is that we can apply this localized hemodynamic restriction to the extremities.
Because the hands and feet aren't core organs. Which makes sense because the textbook details acral erythema or hand-foot syndrome. This is a severe toxicity where agents like 5-FU and doxorubicin cool in the peripheral capillary beds, causing intense redness, swelling, and blistering pain on the palms and soles.
Right. And just like the ice chips for the mouth, we use regional cooling of the hands and feet. Placing them in cold immersion during the intravenous infusion causes the peripheral capillaries to constrict tightly.
It just shunts the blood away.
Yeah, it shunts the blood and the chemotherapy away from those specific tissues, drastically reducing the local toxicity.
It's amazing how mechanical some of these interventions are, just restricting blood flow. But if that drug escapes the blood vessel entirely, the consequences are catastrophic.
Oh, absolutely.
The text emphasizes the severe risks of vesicant extravasation. If an anthracycline like doxorubicin leaks out of the vein and into the surrounding arm tissue, it doesn't just irritate the area.
No, it binds to the tissue DNA.
And it causes progressive deep tissue necrosis that can literally destroy tendons and nerves.
It's a true oncologic emergency. And on the internal systemic side, we see profound hepatotoxicity. Drugs like irinotecan can cause steatohepatitis.
Steatohepatitis, so it mimics fatty liver disease.
Exactly.
Yeah.
Irinotecan is a great example of metabolic toxicity. The drug is processed by the liver into an active metabolite called SN38, which is then excreted into the bile.
Okay.
But in the process, it generates massive oxidative stress inside the hepatocytes, impairing their ability to process lipids. The liver cells rapidly accumulate fat droplets and become deeply inflamed, looking just like severe late-stage fatty liver disease.
The collateral damage of this approach is just staggering, and the sheer level of systemic toxicity is exactly what forced a complete rethink in how we approach the disease. I mean, if carpet bombing the entire rapidly dividing cellular population was destroying the marrow, the gut, and the liver, oncology had to adapt.
Right.
Which brings us to the second pillar, targeted therapies, the sniper rifle.
This is a massive paradigm shift. Instead of attacking all cellular division, scientists began mapping the specific genetic mutations and overexpressed proteins that drive tumor growth.
So we're looking for specific targets.
Yes. We developed monoclonal antibodies, or mAbs, which are engineered proteins that bind to specific receptors on the outside of the cell. And we developed small molecule tyrosine kinase inhibitors, or TKIs, which slip inside the cell to block the internal signaling pathways.
Right. The classic examples being imatinib, a TKI targeting the abnormal BCR-ABL fusion protein in chronic myeloid leukemia, or cetuximab, an antibody targeting the epidermal growth factor receptor, or EGFR, on the surface of colon and lung tumors.
The theory was precision. But as the textbook meticulously documents, even highly specific molecular targets come with their own unique and sometimes lethal off-target effects.
Because these targets aren't just on cancer cells.
Exactly, because these molecular targets are rarely exclusive to cancer cells.
Let's look at gastrointestinal toxicities under this targeted lens. When you administer an anti-VEGF therapy, like bevacizumab, the goal is to starve the tumor.
Right.
VEGF is vascular endothelial growth factor. Tumors secrete it to grow new blood vessels to feed themselves. Blocking it sounds like a perfect strategy, but the text notes a very real, terrifying risk of GI perforation with this drug. Why does that happen?
Because VEGF isn't just a tumor growth factor. In normal physiology, VEGF is absolutely essential for the maintenance and repair of the gastrointestinal mucosa.
Oh, I see.
Yeah, every time you digest food, there is microscopic trauma to your intestinal walls. Your body constantly uses VEGF to signal the local microvasculature to heal those tiny scrapes.
So when you block it systemically...
When you systemically block VEGF to starve the tumor, you also paralyze the gut's ability to heal itself. A microabrasion that would normally heal in hours becomes a small ulcer, which deepens, eventually leading to a full-thickness perforation of the bowel wall.
You are literally dismantling the body's maintenance scaffolding. And we see similar structural failures with dermatological toxicities. Specifically, the textbook highlights the acneiform rash associated with EGFR inhibitors.
Yes.
It's a severe papulopustular eruption on the face, scalp, and upper chest. And here's where it gets really interesting, and where I have to push back on the very concept of targeted therapy.
Okay.
If a drug is specifically engineered to target a mutated EGFR receptor driving a lung tumor, why does it cause such a catastrophic breakdown of the patient's face and scalp? Do these patients have tumor mutations in their skin?
It's a vital question, and it really exposes the limits of the word targeted. The patients do not have mutated skin. The issue is that the wild-type, normal EGFR pathway is fundamental to the survival and differentiation of basal keratinocytes, the foundational cells of the skin.
So you are medically inducing a profound skin barrier failure.
Exactly.
Yeah.
When you administer an EGFR inhibitor, it circulates systemically and binds to the normal receptors in the epidermis. Without EGFR signaling, the keratinocytes arrest.
They just stop working.
They stop migrating and maturing. The skin thins, the hair follicles become inflamed, and the barrier function collapses. Microbes that normally live harmlessly on the skin surface suddenly trigger a massive chemokine release and local inflammation.
And isn't it worsened by the sun?
Yes, interestingly, this is exacerbated by UVB-mediated skin damage, meaning ordinary sun exposure acts as a massive inflammatory catalyst. But clinically, there's a fascinating paradox here.
The rash as a surrogate marker.
Yes. The severity of the acneiform rash is frequently a positive predictive marker for tumor response.
Wait, really? So the worse the agonizing skin rash is, the better the drug is fighting the internal cancer?
In many cases, yes, because it proves pharmacodynamically that the drug is achieving excellent systemic blockade of the EGFR pathway. If it's hitting the skin receptors that hard, it's hitting the tumor receptors that hard.
That is wild. The toxicity literally acts as a real-time biological readout of the drug's efficacy.
It does.
But even these targeted sniper rifles eventually hit a wall. Tumors are highly mutable. They alter their receptor shapes or find alternative signaling pathways, rendering the targeted therapy useless.
Which is incredibly frustrating clinically.
Right. And this evolutionary arms race led to the third pillar detailed in the text: immunotherapy.
And this requires a completely different conceptual framework. We stop attacking the tumor directly. Instead, we recognize that the immune system is highly capable of destroying cancer cells, but the tumor has evolved mechanisms to hide from or suppress the immune response.
So immunotherapy takes the brakes off the patient's own T cells.
Exactly.
We are unleashing the hounds. The textbook covers agents like interleukin-2, a potent immunostimulatory cytokine. It discusses chimeric antigen receptor, or QRR, T cells, where a patient's own T cells are harvested, genetically engineered to hunt a specific tumor antigen, and infused back into the body.
And crucially, it details immune checkpoint inhibitors, or ICIs.
Right, which block the specific off switches like PD-1 or CTLA-4 that tumors use to put T cells to sleep.
But when you remove the immunological brakes systemically, the T cells don't just attack the tumor. They lose their peripheral tolerance to normal tissues.
Collateral damage again.
Yeah. This introduces an entirely new toxicity profile. We move away from direct chemical cellular damage and instead see profound autoimmune-like syndromes, termed immune-related adverse events, or IRAEs.
And characteristically, they all end in itis, pneumonitis, where the T cells inflame the lung interstitium, colitis, causing severe autoimmune diarrhea, hepatitis in the liver, and profound endocrinopathies.
Yes?
The specific trajectory of immunotherapy-induced thyroiditis is a perfect example of how this damage unfolds. It's not just a slow decline in function, is it?
No, it's an explosive biphasic event. First, the hyperactive cytotoxic T cells infiltrate the thyroid gland and physically rupture the thyroid follicles.
Ouch.
Yeah. This causes an initial phase of destructive thyrotoxicosis. All the preformed thyroid hormone stored in the gland dumps into the bloodstream at once, plunging the patient into acute hyperthyroidism. They experience tachycardia, severe anxiety, and tremors.
But the gland is basically burning down. So once that stored hormone is cleared from the blood, the patient inevitably crashes into permanent hypothyroidism.
Exactly. The factory is destroyed, and they will require lifelong synthetic hormone replacement.
And we must also discuss cytokine release syndrome, or CRS, heavily associated with CAR T cell therapy.
That's a huge one.
Yeah, when those engineered T cells encounter the tumor, they activate massively and recruit macrophages, triggering a systemic flood of inflammatory cytokines, particularly interleukin-6. The patient goes into high fevers, hypotension, and massive systemic shock.
It can be fatal very quickly.
So what does this all mean for our clinical listener? This brings up a massive clinical paradox. If a patient's hyperactive immune system is attacking their liver or their colon or flooding their blood with IL-6, the standard treatment outlined in the textbook is aggressive immunosuppression.
Right, steroids.
We use high-dose systemic corticosteroids or specific IL-6 blockers like tocilizumab. But if we just gave them immunotherapy to stimulate their immune system, doesn't giving them high-dose steroids completely defeat the purpose of the treatment we just administered? Aren't we just protecting the cancer again?
If we connect this to the bigger picture, it is the ultimate tightrope walk in modern medicine. When a patient develops a grade 3 or 4 toxicity, meaning severe, life-threatening organ damage, you have to intervene to save the organ.
Right. You can't let them die from the treatment.
Prompt recognition of IRAEs is vital to prevent fatal multi-organ failure. But the biological nuance is that T-cell activation occurs in phases. The goal is to use steroids to dampen the acute, peripheral inflammatory damage in the healthy organs without completely eradicating the central memory T-cell response against the tumor.
You're trying to put the leash back on the hounds just enough to stop them from mauling the owner, but not so much that they forget how to hunt the tumor.
Exactly. It requires meticulous clinical vigilance and constant titration of immunosuppressants.
Now, while chemotherapy, targeted agents, and immunotherapy are all systemic, they circulate throughout the entire vascular network, our fourth pillar is highly localized: radiation therapy.
Right. Radiation is the targeted delivery of ionizing energy. We use high-energy beams to cause double-strand DNA breaks specifically within the tumor volume.
But the physical energy absorbed by the surrounding healthy local tissues sets off a biological cascade that alters that tissue forever.
It really does.
The textbook divides radiation toxicity into two distinct biological phases. First, you have the acute inflammation. As the ionizing radiation physically damages the tissue, it immediately triggers the release of inflammatory cytokines, heavily driven by tumor necrosis factor, or TNF, and interleukins.
This causes immediate, localized burning and alimentary mucositis.
But the true insidious nature of radiation lies in the late-phase fibrosis.
Yeah.
As the acute inflammation resolves, the local cellular environment heavily upregulates transforming growth factor beta, or TGF-beta. TGF-beta is a master regulator of tissue repair, but under radiation stress, it becomes hyperactive.
Right. It aggressively stimulates fibroblasts to lay down massive amounts of collagen.
The tissue loses its elasticity. It becomes rigid, fibrotic, and poorly vascularized. The textbook calls these consequential late effects. But of all the toxicities we've discussed today, the one that absolutely blew my mind was the radiation recall phenomenon.
Oh, it is truly one of the most remarkable physiological mysteries in oncology.
Let me make sure I have this mechanism right. A patient gets radiation to a very specific spot on their chest. The acute burn heals, Months, or maybe even years go by.
Right.
Then they relapse, and they were given a totally different systemic IV chemotherapy drug like paclitaxel or doxorubicin. Suddenly, they develop a severe, blistering, inflammatory reaction on their skin, but only in the exact geometrical shape and location of the old radiation beam.
Yeah.
How is that possible? The drug is circulating everywhere. How does the skin remember the exact shape of a radiation beam from a year ago? How is a cellular memory like that even possible?
This raises an important question, and it is a fiercely debated topic in radiobiology. But the prevailing hypothesis centers on a localized priming effect. We believe the original ionizing radiation permanently alters the local stem cell pool and the vascular endothelial cells in that specific area.
So it changes the baseline.
Yes, it permanently lowers their inflammatory threshold. To the naked eye, the skin looks completely healed, but molecularly, that specific square of tissue is sitting on a hair trigger.
A cellular tripwire.
Precisely. When you introduce the systemic chemotherapy drug a year later, it causes a very mild subclinical release of inflammatory cytokines throughout the entire body.
Right.
For normal, healthy tissue, this tiny bump in inflammation goes completely unnoticed. But for that primed, previously irradiated tissue, it's the spark that hits the tripwire. That tiny systemic signal pushes the compromised vascular bed over the edge into a full-blown, localized inflammatory meltdown.
The physiological memory of tissue is just staggering. It never forgets the trauma. Well, to ensure that you, our listener, our medical student, or young professional, have truly internalized this comprehensive summary, we're going to transition to a rapid-fire clinical review exercise. Let's apply this physiology to the clinic.
I'll present a brief clinical vignette based on the text. Imagine you are the clinician on duty.
Okay.
A patient with metastatic cancer presents to your clinic. You review their lab work, and it shows an absolute neutrophil count, or ANC, of 800 cells per microliter. Upon physical examination, the patient complains of a severe, deeply painful erythematous rash.
Ouch.
When you inspect it, the redness, swelling, and blistering are localized exclusively to the palms of their hands and the soles of their feet. Reviewing their active medication chart, you note they are currently receiving a continuous infusion of 5-fluorosil.
Okay, listener, 2 questions for you to mentally answer right now based on our deep dive. Question 1. What specific grade or category of neutropenia is this patient experiencing based on that ANC of 800? And question 2. What is the specific dermatological diagnosis for their rash? And what mechanical, non-pharmacological management strategy should you implement based on the text? Take a second and lock in your answers.
Let's break down the clinical logic. For question 1, an ANC of 800 classifies as moderate neutropenia. Remember, general neutropenia falls below 1500, but moderate is specifically defined as an ANC between 500 and 1000.
Right. Severe neutropenia, where infectious risk skyrockets, would be an ANC less than 500.
Exactly. And for question 2, the diagnosis is acral erythema, widely known as hand-foot syndrome. It is a hallmark toxicity caused by the continuous infusion of pyrimidine analogs like 5-fluorosil pooling in the extremities.
And the non-pharmacological management.
You want to utilize regional cooling or cold immersion of the hands and feet. This forces local vasoconstriction, shunting the blood and the drug away from those capillary beds, along with instructing the patient on limb elevation and the strict avoidance of friction.
Excellent. If you successfully applied the mechanisms to that scenario, you are well on your way to mastering the clinical management of these adverse events.
Absolutely.
As we wrap up this deep dive into the Handbook of Cancer Treatment-Related Toxicities, the overarching theme is intensely clear. As our oncologic therapies become more advanced, more targeted, and successfully extend patient survival, the mastery of treatment-related toxicities is no longer a subspecialty.
No, it is the absolute core of modern medical practice. You cannot be an effective provider unless you deeply understand the physiological battlefield these drugs create.
You have to respect that the mechanism of the disease and the mechanism of the cure are inextricably linked.
They really are.
Which leaves me with a final, lingering physiological thought for you to chew on. We learned today that the severe acneiform rash caused by EGFR inhibitors actually acts as a surrogate marker. It proves the drug is hitting the target and predicts a better tumor response.
Right.
As we map more and more of these intricate cellular pathways, are we approaching a future of oncology where we might intentionally induce mild, localized toxicities as real-time biological readouts of our therapies? Could we design drugs that deliberately trigger a visible, harmless skin reaction as a dashboard, confirming to the physician that the internal cancer is dying? Is the cure fundamentally, inescapably intertwined with the poison?
It's a profound biological question to consider as you step back onto the wards.
Thank you for joining us on this deep dive. Keep learning, keep applying this complex physiology to your practice, and never stop questioning the medical world around you.